Hello and welcome to the Medic's Guide. Today we're going to cover Systemic Lupus Erythematosus, or SLE for short. So as always, grab your pen and paper and let's get started. So SLE is an autoimmune condition characterized by multi-system involvement. It's a rare condition, but is more common in women, predominantly Afro-Caribbean women, where it's much more prevalent than compared to the rest of the population. Now, this is probably due to hormonal involvement, where it's well known that things like estrogen and other hormones like prolactin can actually activate and promote autoimmunity and increase B-cell activation. And the activation of T and B cells ends up leading to cytokine release and complement activation, as well as auto-antibody production, which then leads to organ damage. Now, there's no single causative agent for SLE, but rather the disease arises from a complex interplay of genetic, epigenetic and environmental factors. Now, as I mentioned, SLE is a multi-system disorder, and in fact all organ systems can be involved and can therefore present in a variety of different ways. It can also range from mild to very severe and life-threatening. Now, I thought the best way for me to explain this to you is to just point out which organ systems are involved on the diagram so you can kind of understand how SLE can present. Now, constitutional symptoms are usually found in initially over 90% of patients, so these are very general things like fatigue, fever, loss of appetite and weight loss. And almost half of SLE patients will have a fever, so it's always good to rule out infections as a cause first. So moving from top to bottom, neurological involvement, whilst uncommon, can present with seizures and psychosis. It can also manifest as headaches in around 50% of causes, and it's also important to know that SLE patients are high risk for strokes too. Now, over 80% of patients suffer from mucocutaneous involvement. Skin lesions can present in many different ways, but it's important to look out for these ones. So first of all, the localized Malar photosensitive lesion, also known as the butterfly rash, which is found on the face, usually the cheeks and the nasal bridge. It's usually quite acute but can last for several weeks. The Malar rash can also come and go with flare-ups of SLE too, but the good thing is that these lesions usually heal without any scarring. Now, you can also get these papular squamous lesions that are usually more widespread over the body. They can look really similar to psoriasis and they can be scaly as well. They can last for several months as well, and they are triggered by certain antibodies being positive as well, so we'll come on to that shortly. Now, discoid rashes are more commonly found in chronic disease. These lesions are disc-shaped with sparing in the center. They can come up anywhere on the body, and if they appear on places like on the head, then it can result in alopecia, which is loss of hair. They can also be seen in the oral cavity, so it's really important to examine the mouth for them too. So in terms of mucocutaneous involvement, I want you to remember the butterfly rash, the discoid rash, but also remember that there are other presentations as well, so you can get those scaly papular squamous lesions, and so just bear that in mind. Moving on, ulcers are very common in SLE. They're usually found in the oral and nasal cavity. They're usually painless but acute, and again another reason why it's important to examine the mouth. Now, musculoskeletal involvement is common with over 80% of patients having symptoms. SLE is usually symmetrical inflammatory polyarthritis affecting the joints, the wrist, the knees, although other joints can be affected. Now, it can mimic other conditions like rheumatoid arthritis because you can get things like ulnar deviation and subluxation of the MCP joints, so just bear that in mind. And you can also get things like Raynaud's phenomenon as well. Hematological involvement can result in anemia being present. This can be anemia of chronic disease, but it can also be other types like iron deficiency and autoimmune hemolytic anemia. The cardiorespiratory system can be involved, and SLE can lead to pleural and pericardial effusions as well as pericarditis. The renal system can be involved and is a common complication of SLE. Lupus nephritis can present with hypertension, hematuria and elevated creatinine, but generally you're going to be having to do biopsies in order to determine the prognosis when this happens. Of course, there are other manifestations and things like gastrointestinal and esophageal motility issues can occur, and you can get eye involvement as well. So generally, as you can see, there's a lot of different presentations. It's just really important to try and remember some of these common ones. Now, the majority of patients will have elevated levels of autoantibodies, particularly against nuclear components such as nucleosomes, DNA and histones. and it's generally accepted that some of these play a part in the pathogenic role of this disease. Now, one of the most important ones, ANA, anti-nuclear antibodies, which is the hallmark serological feature of SLE, with the majority of patients having a positive ANA at some point during their disease course. Therefore, ANA is a very, very good screening test for SLE. The thing is, it's got a high sensitivity but not a high specificity, and that's because ANA is found in various other conditions like rheumatoid arthritis, Sjogren's, even autoimmune hepatitis and MS. So it's useful after seeing a positive ANA to do some further specific testing to detect the antigen causing the positive ANA. Anti-dsDNA or anti-double-stranded DNA have a very high specificity for SLE at more than 95%, meaning if you see anti-dsDNA positive, it's almost certain that they have SLE. But the problem is here that 60 to 70% of them only have a positive, so it's got a low sensitivity. Anti-Smith is probably one of the best tests with a 99% specificity for SLE. However, it has a low sensitivity and only 30% of patients have a positive result. They're also more commonly found in African American patients too. Now, complement is commonly used as a marker of disease activity. Now, in active disease, serum complement levels are usually reduced, and these patients are at much greater risk of developing serious infections, especially from encapsulated organisms. So these are things like Streptococcus pneumoniae and Neisseria organisms, and you might need to give them antibiotics as a prophylaxis. Whilst not an investigation, examination is really, really important. So examining the skin, examining the joints, the neurological system, as well as the cardiac system as well. So these are just really important things to do. Now, some blood tests that you should always really do with these patients: a full blood count, which can demonstrate cytopenias. Renal and liver function tests should always be done. Urine analysis should also be done to check for renal involvement, as well as see if there's any proteinuria. And if present, depending on the exact presentation of the patients, then you may need further investigations. So, for example, if they've got arthritic type pains, you may need to do the x-rays. If they've got discoid rashes and other rashes, then skin biopsies. If they've got renal involvement, then renal biopsies. And as you may know, they can get pericardial effusions and pericarditis, so chest imaging and echoes are things that you might need to consider as well, and MRIs as well, so just bear that in mind. Now, this is just the criteria of things that you should look out for with lupus, and as you can see, there are a lot of the things that we've already mentioned, and the immunological criteria, the ANA, anti-dsDNA, anti-SM, and the complement level. So just bear that in mind, have a look at this, have a read, pause the video, and just make some notes on that if you'd want. Now, SLE is associated with a condition known as Antiphospholipid Syndrome. Now, it's important to know this because during pregnancy, SLE can flare, and patients with SLE who have antiphospholipid antibodies are at a very, very high risk of fetal loss due to miscarriage. And the reason why this happens is because some of the antibodies, anti-Ro and anti-LAR, can actually cross into the placenta and cause fetal heart block and neonatal lupus. Now, the patients who have a cardiorespiratory involvement are at a very, very, very high risk of serious complications, and so you must monitor them very closely. Now, moving on to the management, the treatment. Mild SLE can be treated with antimalarials, so things like hydroxychloroquine alone are really good, but sometimes you might need to give them something stronger. The good thing about hydroxychloroquine is that it's really good at preventing flares, it's good at managing arthritis and lupus, as well as managing some of the cutaneous features like the rashes and ulcers. It's safe to use in pregnancy, and it helps reduce that risk of fetal heart block. It has antithrombotic properties too, which is important considering that we mentioned that SLE patients are at high risk for strokes as well. However, having said that, one of the side effects of hydroxychloroquine is that it can cause damage to the macula, so these patients will need regular ophthalmology examinations to monitor this. Now, during a flare-up, corticosteroids are used. Again, these have significant side effects, especially long-term, and so things like reduction in the amount of steroids that we're giving is a new goal when treating SLE at the moment, because new evidence is actually emerging that steroids actually are causing more damage than the actual condition lupus itself. Now, other stronger immunotherapies, things like DMARDs, biologics are often used now as well. Things like cyclophosphamide, azathioprine, and infliximab, these are often used in more severe disease. So as always, I've got a really good way for you guys to remember this. Now, I hope that some of you have watched House, because if you know that Dr. House always mentions lupus. So I've got a really good mnemonic, MD Hugh Laurie. Hugh Laurie is actually Dr. House's real name. If you remember this, you're going to remember everything that you need to know about lupus. So let me break it down for you. M for Malar rash, Discoid rash, hydroxychloroquine, ulcers, generalized symptoms, hematological involvement, low levels of complement, arthritis, uncommon because it's an uncommon condition, renal lupus, immunological criteria, so that's things like the anti-dsDNA, ANA, anti-Smith, and effusions. You remember all of that, and you've remembered everything that you need to know for this condition. You're going to be able to get every question in your exam right. Tell yourself this every day and you'll have it remembered in no time. I hope that helps. Just finishing off with a question now. A 25-year-old woman presents with a 1-week history of fatigue, fever, and sharp right-sided chest pain, which is worse on inspiration. She also complains of intermittent joint pain in her hands, which have been present for approximately 4 months. On examination, there's mild erythema over her cheeks. Which of the following investigations is the most sensitive for this condition? So let's break this question down, as we know that it's more common in women with a 9-to-1 ratio. So bear that in mind. Remember that these patients get generalized symptoms, so things like fatigue, fever, really, really important to remember. The sharp right-sided chest pain, which is worse on inspiration, so that's pleuritic chest pain. We know that things like pericarditis can present with pleuritic chest pain. Intermittent joint pains on the hands, as we know this could be the arthritis, and there's also the mild erythema over her cheeks, and that could be that butterfly rash found on the face. So given this history, we kind of know that it is SLE, but the question is asking which of the following investigations is most sensitive for this condition. Now automatically a lot of you might just go towards anti-dsDNA, but you need to remember that anti-dsDNA is a very specific antibody. It's not very sensitive. ANA, however, is the most sensitive with over 95% sensitivity, and so that's what the answer is here. So just bear that in mind. Remember the difference between sensitivity and specificity. Anyway, that's all I have for you today. Thank you very much if you made it this far in the video. Remember to just like, comment and subscribe. If you've got any conditions that you want me to cover, drop them in the comment section below, and we'll be back with a new video soon.